sinus surgery. Please welcome.
Good afternoon, everyone. Hope you are not so sleepy after a big lunch. Today I'm talking about the frontal sinus surgery and concentrate more on how to manage the frontal cells. So the objective of my talk is to first identify the frontal cell according to the new classification IFAC and predict the frontal drainage pathway and how to manage the frontal cells correctly. As you know, the frontal sinus surgery is still the challenge for most of the rhinologists because of its complex anatomy. This is the classical codes in classification. In this classification, you have T1, T2, T3, T4, frontal bular cell, suprabular cell, interfrontal sinus septal cell. In 2016, there are new classification IFAC by Wormwood et al. This is more precise anatomically and relevant surgically. So in this classification, you can see the anterior cell, including the agar. Above the agar, we have the supra-agar, and if the cell is extended to the frontal sinus ostium, you have the supra-agar frontal cells. So SAC is the T1, T2, and SAFC is just T3 or T4. Posteriorly, you have the suprabular cell, and if the cell extends to the frontal sinus ostium, we call the suprabular frontal cell. And we also have the supraorbital ethmoid cell and the frontal septal cell. I draw a diagram for you to remember easily. This is the agar, this is the bular posteriorly, and this is the frontal sinus ostium. If you have a cell above the agar, we have the SAC. If the cell extends to the frontal sinus through the frontal ostium, we call it supra-agar frontal cell. Above the bular, we have the suprabular cell, and if the cell extends to the frontal sinus ostium, we have the suprabular frontal cell. So it's easy to remember. So this is the supraorbital ethmoid cell. The cells, the posterior base cells. So when you have the supraorbital ethmoid cell, almost all cases you will have the anterior ethmoid artery in mesentery like this. So be careful not to injure it during the surgery. So how to recognize the anterior ethmoid cell? You see here the anterior ethmoid cell. It's a supraorbital ethmoid cell. It's the anterior ethmoid artery mesentery, and normally most of the time you will have a septation between the frontal sinus and supraorbital ethmoid cell. This is the case. In this case, we have the agar here. Above the agar, we have a supraagar frontal cell. And this patient, we also have the supraorbital ethmoid cell, and this is the anterior ethmoid artery in mesentery. About the frontal cell and the frontal drainage pathway. In the frontal sinus surgery, identification of frontal drainage pathway is considered to be the most challenging part of the endoscopic sinus surgery. Accurate identification of frontal cells and awareness of their usual influence on the pathway can facilitate this process. When you identify the cell and you identify the frontal drainage pathway, you just simply dissect the frontal cell by placing the instrument in the pathway and break the cell and clean it and to avoid the skull-base surgery. So we recently published a paper using the scopic building block software because due to the ease of localize the cell and draw the frontal trained pathway more accurately to examine the prevalence of frontal cells and also the most common frontal sinus trained pathway. So in our study, the most common cell is the suprabular cell, account for about 46%, and the second one is the supraagar and supraorbital ethmoid cell, account for about 16 to 17%. It's similar to other study among the Asian people population. In Caucasian people, the supraorbital ethmoid cell is the most popular compared to the suprabular cell. Interestingly, we can find the most common frontal sinus drainage pathway in relation to the frontal cells. In relation to the anterior base cells, to agar is posterior in about 65%, medial in about 32%, but in relation to the SAC and SAFC, it's more medial to those cells, accounting for 70% and 81%. So if you have the higher cell like SAC and SAFC, it's more medial than the posterior to that cell. For the posterior base cell, is 100% of cases is posteriorly to the suprabular frontal cell and supraorbital ethmoid cell. So here an example. This is the agar, supraagar, bular, suprabular, and we draw the frontal drainage pathway. And in this case, the pathway is medial to the supraagar cell and anterior to the suprabular cell. Now I'm talking about the classification of frontal sinus surgery. This is the classical trap classification. We have trap 1, trap 2B, 2A, 2B, and trap 3. Also in the international new classification, we have the new classification of endoscopic frontal sinus surgery from 0 to 6. Grade 0 is a balloon dilation, sinusoplasty. Grade 1, grade 2, 3, 4. Grade 5 is trap 2B. Before we don't do the trap 2B very often, recently with the use of flap, such as the Caroline windows by Richard Harvey, and trap 2B also have good result with less scarring. Grab 3, you clear the cell pneumatizing through the frontal sinus ostium without enlargement of the frontal sinus ostium, which is not present in the old classification. So again, I draw a diagram. This is the case of grade 1 and grade 2. This is agar, supraagar, suprabular. You can clear all the cell without touching the frontal sinus ostium. So that's a grade 1 or grade 2. Grade 3, if the cell extends to the frontal sinus ostium like a suprabular frontal cell, supraagar frontal cell, you still can get it without enlargement of the frontal sinus ostium if the patient has the big frontal sinus ostium. So that's the grade 3. Grade 4, you have to drill the frontal beak in order to take this frontal supraagar frontal cell and suprabular frontal cell. So that's the grade 4. And grade 5 and grade 6 is trap 3. So how I do it? First, I identify a frontal cell with a triplan SED, or you can use the software to identify it. And then you identify the frontal drainage pathway and then how the pathway runs around this cell. And next, you plan the grade of surgery to tailor for the flap. And normally, grade 1, grade 2, no flap. You can either do the IGS if it's complicated. Now, when I do a lot of surgery and gain more confidence, I don't use the IGS most of the time. I just use for revision cases or when you do the suprabular cell or suprabular frontal cell, suprabular frontal cell. I sometimes use the FGS. And then you pass the instrument along the pathway and fracture the identified cells to clear the way. And remember, the instrument should not be passed through the roof of the cell because the risk of anterior cranial fossa if mistaken identification of the cell or pushing the instrument with the wrong direction. This is the instrument. You need the curved instrument, a micro debrider, and also my favorite instrument is the section correct, a malleable one, so you can reach almost the cells. I recently prefer to do the intact bular technique. After I do the antrostomy, I use the 30 degree to check for the antrostomy, remove the polyp in the maxillary sinus, and then I turn it on and do also the frontal sinus surgery with intact bular technique. So if you do the intact bular technique, you can protect the skull base and anterior ethmoid artery better. So this is a case to demonstrate the patient have the agar here and supra-agar frontal cell, and he also had the anterior ethmoid artery in mesentery, and also the supraorbital ethmoid cell bilaterally. This is the supraorbital frontal cell, and we know that the frontal tract drainage pathway medial to the cell, and we break the cell and remove the cell. So after removal of the SAFC, we dissect the SOAC, and you can see here the SOAC. Yeah. Okay. So another case, we have here the agar. This is the supra-agar frontal cell, suprabular cell, and SOAC. In this case, we use the software to identify the frontal drainage pathway. It's medial to the supra-agar frontal cell and anterior to the suprabular cell. This SAFC is open up, and posteriorly we dissect the suprabular cell. We always preserve the mucosa, just take the bony septation and then clean the rest of the mucosa with the microdebrider. You can see here this intact bular technique. The bular is still keep intact. We do it later. This is another case. This is the agar, the supra-agar frontal cell, and the patient also have the supraorbital ethmoid cell. This is a post-op of the patient after 3 months. You can see here the SOAC with the anterior ethmoid artery in the mesentery. This is the frontal sinus, a little remnant of the SAFC. Another case, bilateral SOAC, and also this is interfrontal sinus septal cell during the surgery. We still have time. Okay, this is the more complicated case. It's a recurrent IP, inverted papilloma. You can see here the papilloma, mostly in the supraorbital ethmoid cell, and also some adhesion of the papyracea, or also the skull base. So in this case, it's very difficult to get the tumor from the supraorbital ethmoid cell. So we have to do the flap free. You have to go from this side to remove all the cell. This is after the flap free. You can see a lot of inverted papilloma. In this case, we still preserve the periorbiter and just do a very low dose of the low energy of the bipolar to clean the remnant of the papilloma at the periorbiter. So bipolar at the periorbiter. And this is the final look. Oh, this one is later. That's where my conclusion. Sorry. So anyway, I like to take this opportunity to, on behalf of the chair, the president, Dr. Soma here, to invite you to the ASEAN Rhino. It will be held on 16 February to 18, 2000.